Well, hello everyone on Zoom, and hello to everybody here in the room as well. I'm going to do a quick pan so we can have a quick wave. Hello! We've got conference tables officially set up in the shape of vocal cords today. So welcome to our fall member meeting and presentation from the University of Washington Performing Voice Clinic, Demystifying Vocal Injury Treatment and Evaluation. And my name again is Megan Parker, your chapter president. I brought the snacks for today. And we're so delighted to welcome from UW, Dr. Bott and Julie Rosenzweig. And I'm gonna have her unlock her phone one quick second so I can read delightful bios. Sorry, it locked for me. Ha ha ha. Takes a village. All right, I want to introduce you today to our folks in the background. We have with us Neil Bott, MD, is an assistant professor and is part of the Division of Laryngology. He completed his fellowship at the University of Southern California and has a passion for performing voice care. Dr. Bott's research interests involve understanding the neuromuscular changes in the aging voice and developing new regenerative therapies. And we also have Julie Rosenzweig, MS, CCC-SLP, member of SAG-AFTRA. Oh, I'm going to read it all. It's true. Aren't we glad? Yes. We have people in the room here too, so I'm directing all this to Zoom. Julie is a speech-language pathologist who specializes in laryngology at the University of Washington Medical Center, where she has worked since 2000. Julie is passionate about working with performers who are struggling with voice challenges, and she has an extensive background in the theater as a performer and voice and dialect coach. So everyone on Zoom and everyone in the room, please give a round of applause to the UW Performing Voice Clinic today. Hooray! And I'll hand it off to them. Mm-hmm.
Thank you so much, and thank you guys for inviting us. It's a pleasure. Meeting other teachers in the community really helps us to form these bonds of communication so that we can take care of your people and then you can take care of our people, and that's how it works well for everyone. I just wanted to say that this is the topic, demystifying vocal injury, eval, and treatment. As Megan said, I'm Julie, this is Dr. Bott, and then we can go on. Am I poking this, or are you poking it? You should poke it. Okay, that's good. Okay, so I wanted to introduce you to the full team. Unfortunately, Dr. Gilberto is not able to join us today, and he and Andrew are partners, so they left and we stayed for personal tragedy. So this is Andrew Lee, that's me, Dr. Bott, and Dr. Gilberto, and we all work as the Performing Voice Clinic. We do have additional laryngologists who work with us who are 100% capable of helping folks with performing voice issues, including Dr. Marati and Dr. Meyer. But we're the dedicated team who tries to give access to performers more quickly. So if you have somebody with an acute injury, they're going to end up in our clinic probably. Yeah? What's next? Oh, this is fun.
The spot is on the key again. How hard did he hit him? We were away a year ago. We eat eggs every Easter. My mama makes lemon muffins. Peter will keep at the peak.
That's Abby Carlson, and that
Today I'm
was...
here for a voice evaluation, as I'll be starting a new choral endeavor, and I want to make sure that I have a good baseline to get started with.
Abby just graduated as our clinical fellow, and this is a video stroboscopy of her. She doesn't have any complaints, but she's demoing for us.
Go ahead and say kitty cat.
Kitty cat.
Good. Say shh. Good. Breathe through your nose, seal your lips. Good. Go ahead and swallow once for me. I'm going to dim the lights for better contrast. And give me a long, strong E. Good. Good. E and sniff alternate 3 times. E, E, E. Good. And count to 10 quickly.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Say, we mow our lawn all year.
We mow our lawn all year.
Pay Paul a penny.
Pay Paul a penny.
Nice. Tell me what you're going to do this afternoon.
This afternoon, I'm going to take my dog for a walk.
Beautiful. All right, you ready to sing?
Sure. Let me give myself a little starting note here. Oh, mio bambino caro, mi piace bello quando rincorda rossa a comperar l'anello.
Beautiful. Okay, and then go ahead and straighten up just a bit if you could. Terrific. And then if you can see on the screen, this structure down here is the base of your tongue, and that is pulling back a bit. I want you to go ahead, pretend that the sound doesn't matter, which I know is nearly impossible. See what happens if you relax your tongue a little bit, if it makes it a bit easier. Does that feel any different?
A little bit.
Cool. Okay. Anything else you'd like to see Dr. Bott?
All right, we just threw you into the deep end there.
Cool.
So that was, as I said, Abby Carlson, and that would be a typical type of singing evaluation that we do. We're going to back up a little bit and talk about why do people come to the clinic? Why do performers end up in our clinic? Sometimes it's for a baseline evaluation. They're totally fine. They just want to see what's going on. They're at Cornish or wherever. Another reason might be that they have a voice change that doesn't resolve within a couple of weeks. They might have complaints of pitch instability, decreased stamina, pain, quality change, delayed onset in voicing, especially in the high pitches. Those are all good reasons to have a peak. Another thing is that in spite of the fact that their technique is great, they might not be able to continue to progress, and that would be something that you guys would be looking out for. Any of these things would be great reasons to refer people over. And then urgent-wise, if somebody has a sudden loss of voice, we want to make sure that we rule out hemorrhage right off the bat. If they have a performance coming up and they've had a voice change, maybe they've been in rehearsal for 3 weeks and things are going downhill, that's a good reason to have them come in. And then they might be in ongoing rehearsals, their voice is getting worse and worse over time, we want to see them. And then the biggest part is that you guys, as I said at the beginning, are our partners. So we count on you listening to your clients, your students, to then bring them to us for help. And as I said, we do the same thing when we're like, okay, the way that you're using your speaking voice is awesome, goodbye. So it's not that, so I will do a basic singing evaluation to see if I can tease out, well, you know, there are a couple of things that I really see in singers with breath conservation, not allowing that breath flow to come through, using resonance that's much more about pressing than floating and vibrating. And I can mess with that a little bit, but I'm going to hit my ceiling pretty fast. And then I'm going to want you guys to help us. Yeah? Did I say everything? There's something about 48 hours. Oh yeah. That our goal is to see singers with acute problems within 48 hours. So not only Dr. Bott and Dr. Giliberto, but also in a last ditch, the speech pathologists can scope and rule out hemorrhage. And then we also have our 2 other physicians and our laryngeal fellow. So we will get people seeing. And then we try to get people in for a standard evaluation within 2 to 4 weeks. You guys have my card up there with my direct email. You can also always email Perform Voice Clinic, which I also check at uw.edu. You let me know, wow, this person is urgent, or, something's not, they're not that urgent, then I'm gonna put them on in a month or whatever, yeah? Okay. Evaluation. So this is you for a moment.
All right, so I'm gonna talk a little bit about what we look at medically when we see patients. And feel free to stop me if there's anything that doesn't quite make sense. But, I still think this is an otolaryngology visit. And one of the great things that I tell performers when you see them in clinic is that Julie and I are really looking at the performer in very different ways. And so regardless of, it's easy to look at specific voice issues, but I'm taking a step back. So I'm looking at the onset, the duration, the severity, location of discomfort, pain. And I think it's really important to look at the past medical history, including, has this happened before? What other problems do they have? Do they have hypothyroidism, diabetes? All of these could maybe find their way into causing voice changes. Medications, I wrote that specifically, that's a big one. A lot of times people will be taking these medications that severely dry out all their mucosal membranes, and they wonder why they always have this thick, bothersome phlegm that is on their vocal folds. And, family history. A lot of the times, by the time they get to us, the answer is often not clear. And so looking at all these things, I think, are really important.
Should have put the chair here.
Yeah.
So when we do a speech pathology voice-specific evaluation, we want to know what brought you here. What are your symptoms? Are you vocally fatigued? Are you having pain? Where is it? Are you having weakness? Are you having a loss of range? Are you having trouble in your presentatio? Is it your clarity is not clear? Your clarity is not clear. And now for other smart things. Maybe your voice is rough. Maybe you have breathiness. I want to know about the training that you've had. I want to know your style. I want to know your range. I want to know who you studied with. Most of the time, I've never heard of the people, but if somebody comes in and they say, I study with Dr. Kari Reagan, or I study with Christy Linda Rotarius, I know that these people know what they're doing, right? And then I'm going to have a different idea of how much I need to mess with things versus somebody comes, well, I go to the Guitar Center and there's this lady, she's worked there for 2 whole weeks. And I'm like, okay. And then I'll probably send them to you guys, right? Shh, don't tell anyone. What else? Vocal demands. How much are you singing? How much are you speaking? We get those performers who are doing 4 hours of singing every night at a crowded restaurant in a, over noise, serving tables, screaming at the bartender. And so I need to know that stuff. Vocal hygiene, alcohol, tobacco, caffeine, amount of water they're drinking. And then the other thing is, and this is for me really, really important, I'm listening to how they're talking. Yeah, I'm doing an assessment based on what I hear. Roughness, strain, how does their breath flow sound to me? Are they holding? Are they pushing? Are they loud as a bus? Usually. And then another thing we'll do is palpate the larynx to make sure that there's no tension. There often is tension. Am I feeling tension in the thyrohyoid space? That might put me down the road of, I wonder if we did some laryngeal massage, some intraoral massage. So everything is based towards eventual treatment if that's the course that we go.
Yeah. So we started with a real overview of what the clinic visit might look like, at least in the beginning. And one of the things that we do, which I think really separates us, is we try to always get a high quality research voice recording with as many visits as possible. And the reason is because it serves as a baseline, what someone sounded like on a particular day. There is a point of comparison for the future. If we do therapy, observation, surgeries. We want to know, and it's interesting, you can, we all have bias. We all kind of think, oh, you're so much better after the surgery. This is a more definitive way to know that. And so I think this is kind of an important thing to have. So I'm going to get a little bit technical for a second. This is a tool that we use frequently in clinic. This is called stroboscopy.
Hold at the top.
So stroboscopy is a tool. It allows us to look at the vocal folds, but get really good information about the motion, how they're opening, closing, how the vocal folds are vibrating. We can analyze the mucosa. Are there signs of phonotrauma, inflammation, redness? We can look for the pliability of the vocal folds, how symmetrical it looks, how well the vocal folds are closing. So really briefly, stroboscopy uses the fundamental frequency emitted from somebody's voice, and the strobe light is firing at a rate that's just a little bit off from the fundamental frequency to create that slow motion effect. And that's very different than what you will see in a general otolaryngology clinic. So they use something called plain light, which is still really helpful. You can get a lot of information with plain light, but it's very different. So here's just a quick example. Is me doing okay? Yeah. Okay, perfect. We are almost done. Go ahead and say E, and again, E. So I think the right vocal cord is paralyzed. So you can see really good information. You can see that the right vocal fold, screen left, but the right vocal fold isn't moving. You can get a lot of information about the character of the mucosa, how inflamed it looks.
Can you back that up?
Mm-hmm.
Good.
I'm gonna play it again. Is me doing okay? Yeah. Okay, perfect. We are almost done. Go ahead and say E, and again, E. So I think the right vocal cord is paralyzed.
Right cord is screen left.
It's just staying there. It's not
Right.
it's going like this.
Yeah.
Yeah.
Okay.
And what's interesting, you can kind of see it's closing, but it's a blur. The frequency of our voice, male voices, can be anywhere between 90 and 120 hertz. That's 90 vibrations per second. Our eyes can't see that. So you can kind of see just a blur compared to this.
No.
So you can see it's a dramatic difference. And once you do stroboscopy, it's hard to go back. If you asked us to do plain light exams, it would really put having one hand tied behind our back. And then really briefly, I wanted to mention the different ways that individuals can be assessed. So a lot of times, Julie and I will start with a flexible stroboscopy. And the reason is because we can get a lot more global view, transnasal, like we saw with Abby in the beginning. And I think the really cool thing, and as I've worked with Julie more and more, I feel like I'm more warming up to this idea, or actually totally buy in, is that we can see the individual speak and sing.
Yeah.
And so it gets us a lot more information, as opposed to the rigid, which is also really cool. It goes through the mouth, a little less irritating for some. Some people don't like the scope going through the nose. But it's almost impossible to speak or sing because I have a hold of your tongue. Exactly, yeah. So they both have their pros and cons. Honestly, it's at this point a discussion. We step out in the hallway and kind of discuss, well, what's the best way to get what we need? And then we go with that. I can hand it back over to you for this part. Yeah.
So you guys are welcome to come into clinic with your people. Christy's been in with us. And then you can take your client, your student, through whatever it is they're having trouble with while we're scoping to help us see what it is that you're hearing. So you guys are welcome at this point. So we have some strategies during stroboscopy that can help to plan treatment. We didn't have enough time to show each one of these, but one thing might be sighing phonation, like ah. So if I see somebody who's got a ton of muscle tension, we're not going to be able to see what we need to see. I want to see, what do I see when everything's relaxed? I might do inhalation phonation, also an unloading technique. You'll see a very cool picture in a minute of that, where I do, and then that's going to pull the underside of the vocal fold up to show me, and it also helps people to stop straining to speak. We have them do a little donkey, and they're going to be much less prone to going, right? Which is what they were probably doing before. I'll tell people, okay, now I want you to do it as softly as you possibly can. That technically gives me a really good view also, and it also tells me, you know, what does their voice sound like when they're not straining to get loud. A lot of people will be really pushing to compensate for inadequate vocal fold closure or inadequate vibration. I also tell people all the time, which is super popular, that I want them to let themselves sound like poop, right? I don't want them to use all those compensatory strategies that the singer's ear is telling them, okay, yeah, if I just did this, then I could get it to be what I want it to be. So I want to take all that off, because it may very well, first of all, it's exhausting, but second, it may very well be the thing that's perpetuating a lesion. Yeah? Tongue out, if I have people with, did you like that? If I have people who are, yeah, right, who are, you know, have a lot of posterior tongue tension, or if they're singing with a lot of tongue tension. Abby had a little bit of that. I don't think we saw a huge shift. There was a little bit of shift in the way that it sounded. So I may have them do that, and I may do some biofeedback. I told her, look at the screen. We have a second screen that the patient can see, and they can watch the effect that their behavior has on their anatomy. So that's pretty cool. Twang or plus Y buzz are techniques that I'll use if somebody is really posterior and I want to kind of get them out there. And so I'll have them do, okay, try this nya, 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 which is the twang exercise, and see what happens in their throat. So I'm not just looking for the sound change, because I can do that without a strobe. I'm looking for, what does that do for the anatomy? Is it squaring up the vocal folds better? Is it decreasing the tension? Plus Y buzz is a yay sound. Yay, yay. I especially love using that with singers, because you guys get it. Next. Okay, here's a great picture. This is strategy in action. So on the, I want to call that right, but it's probably left, isn't it? On the left side of the screen, this is what we saw in this patient prior to inhalation phonation.
Yeah, you just point
This
behind
one,
it.
yes. Oh, but I have to look at the screen. I have a TV. It's okay, I'm getting therapy. So this one is what we saw before, and I'm wondering, well, how much is under here that I'm not seeing? So I have them do this inhalation, and then you can see this whole gray area coming through, which is all swelling. Yeah? Singing. So I want to see you sing. I do not want you to come in and go and then say, yeah, I don't know why you're having problems. So I'm going to ask you to do an easy song. My colleague Andrew says that helps me to realize if they need habilitation or rehabilitation. I won't go further with that. I'm just going to blame it on Andrew. And then I have them sing a challenging song, or at least singing the notes or the passaggio where they're having trouble. And then what is super cool about that is I can see the compensatory strategies that they're using to try to get over that trouble. Yeah? Treatment options. This is you, huh? Oh, it's still me? For God's sake. Okay. It's you!
Yeah.
So that could be a really easy thing, right? If somebody comes in and their technique is Stinky McStinky Pants, then I'm going to send them to you guys and see how we do to tease that out. That's if their speaking voice is normal and their laryngeal exam is basically fine. Yeah? On the other hand, if we see people who aren't basically fine, or they have speaking voice problems, or maybe they have singing voice problems that are super easily addressed, as I talked about in the beginning, we're going to do some vocal hygiene, anti-reflux stuff, talk about, this is how the vocal cords work, blah, blah, blah. SOVTEs, so I like to do cup bubbles. Flow phonation is under the coordination of phonation and respiration. So with singers, a lot of times I will see that, okay, I've got my ribs out. I don't know what your problem is because I can go over another 35 minutes like this. And I'm like, okay, but you're exhausted and you sound bad. So I try to encourage them to let go and then to learn. And then I send them to you guys. And you're like, okay, try this strategy instead of the one that you learned in 1911 where they told you to be a canister. So, sorry, Christy. Oh my goodness. And then the other thing that I hear a lot with singers is resonant voice. The way that they're getting forward is all about the push. So, hey, how are you? Okay, I don't know what your problem is. I'm forward, right? Bad impression. And then I want to take them into, okay, hey, away, so that they're lofted. Sorry if I just, what do you call that? Blew your ears out. Yeah, so I want to get them to a place where they can use their resonant voice strategies. I think of it as lofted mode 1. I studied with a man named Arthur Lesak, who, if any of you have heard of LMRVT, he's the L of LMRVT. And he taught me a lot. I'm using the microphone over here. Any complaints online?
Not yet. No.
Okay.
You had some belting to do. No, that was good. You're using microphone technique.
There you go. There you go.
Yeah.
I learned that from you.
Uh-huh.
And then my favorite thing to do, my next favorite thing to do, because I like all this stuff, is if I think, wow, this person knows how to sing, but their speaking voice is not great, the mechanics of their speaking voice, I'm going to have them sing. And then I'm going to listen, and when I hear a beautiful resonant, clear tone, I'm going to say, stop there. We're going to make that note again. And then we're going to go down, 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 down into speaking pitch and use that same strategy and hijack it for the speaking voice. So, therapy.
Mm-hmm.
Next.
Great. So I'm going to talk a little bit about medical management. So for a lot of patients, while therapy may be on the table, surgery is generally not where we start. Now, there are rare exceptions. So there's a lot of emphasis on medical management. And like I alluded to earlier, this is obviously looking at the larynx and the vocal folds, but looking at this holistically with how other things are involved. So I like to think of it like levels, looking at the ears, the nose, the sinuses, postnasal drip, reflux, medications. Are they on inhaled steroids? Do they have a maybe opportunistic fungal infection of the throat? And so there's a real opportunity to not have tunnel vision and just look at singing, vocal folds, but really to take a step back. But medical management also, when we rule out some of these other stuff, does sometimes involve treatments for the vocal folds. So one of the common things we do, especially when we are not sure, like for example, let's say we see a phonotraumatic lesion. We see it's on the left vocal cord, but there's a lot of swelling, redness. We're not sure, is this a polyp or a cyst or something else? One of the things that at least we routinely will recommend is a 1-week period of absolute voice rest, plus minus on steroids if the patient is able to take oral steroids. Put them on a pretty moderate to high dose of steroids. And the idea is we cut out all talking, all singing, anything that could add more swelling to the vocal folds. And the steroids help maybe bring out some of the edema, wash that away. And so it's both therapeutic and diagnostic. Therapeutic in the sense that often patients are much better after that 1 week of voice rest and steroids. Diagnostic in that now, if we bring them on the final day of voice rest, something that we routinely try to do, see them on the very last day, then we can see, much more clearly what this is. And sometimes we're shocked. Sometimes we are confident this is a cyst, and then it may be gone, or it may be changed, and now that might change our differential or what we think it is. So medical management is really important. I think it's looking broadly, but it's sometimes often necessary before we get into procedural management. So for a lot of singers, and rightfully so, there's a lot of apprehension about what could be done and whether procedural interventions are offered or recommended. And I would say, unless it's very clear that the patient is not going to get benefit from observation, therapy, connecting with the singing voice specialist, procedures are not generally the first line of treatment. I hope that makes sense. And I can feel it in the room whenever we say, okay, we're not recommending surgery at this point. I think people are just much more at ease. But sometimes we have no choice. Sometimes, despite all our best efforts, we get to a point where we have to do something. And we, as a laryngologist, this is one of the areas that we have additional training in, and that's to minimize the likelihood of anything that could put someone's voice at a worse place. Generally, people are so bothered they're not able to hit their notes or do what they need to, that at the point at which we're recommending procedural intervention, everybody in the room agrees that this is the right thing to do. In terms of procedural intervention, there's two big buckets. So there's what we do in the office and what we do in the operating room under general anesthesia. And there are pros and cons with both of them. If you want to avoid general anesthesia, sometimes people are just not well enough to go under general anesthesia. The in-office procedures are really helpful. And I think, over the last 15, 20 years, especially with the increase in endoscopic technology, the things we're able to do in the office, much, much easier. We have the use of KTP laser, so we can even laser some small blood vessels or lesions in the office and may minimize the risk of an endotracheal tube or general anesthesia. A lot of times that can make it more palatable. On the other hand, when it comes to performers, we want to make sure precision is the key, and if we think we can get a better result under general anesthesia, we'll often do it. I think the take-home message with this is it's a teamwork, and it often requires a handoff between multiple parties. Sometimes we'll start with therapy, and the patient may get all the benefit they need. They're great. We see them in follow-up, and we have them return as needed. But other times, despite all our best efforts on the speech pathology front, we're still struggling. And that's where it's a reassessment. And sometimes it goes the other way. Sometimes we start with procedural interventions, and then we go back to therapy or at the same time. So the point is, there is a little bit of a fluid nature of recommendations. Okay. So I thought it'd be cool if we do some case studies. So I think Julie will start with the first few cases.
Thank you.
Thank you, Dr. Butt.
Uh-oh, you're just unplugged your world.
That's okay.
And for my next trick. Okay, great. So this person that you're about to see is a 35-year-old female who's a professional musical theater performer, sudden onset of dysphonia. She came in with a left vocal fold hemorrhage. Let's show the picture of that. Beautiful. Well,
Can you go about a third or a fifth above that? Gently through your throat again. And make the sound like you're surprised. Good. See if you can pull that out. Do that again. Let all let go. Awesome. Just chin up. Breathe nice and easy.
is anyone in the room breathing?
Ow.
can see it looks like there's a bit of a prominence, but obviously the blood is very eye-catching. Can you go back?
In the light spot there?
Yeah, that.
Yeah, I think maybe some of the blood has cleared from that. I bet if we had caught it right, when it happened, it probably was covered with blood, but with phonation, some of it's probably kind of migrated to the periphery.
So was that what we were looking at? Where it's red, is that blood on top of the cords or underneath? It's underneath, okay.
Mm-hmm.
So when it was phonating and you know, it like a sort of a little spot in the middle cleared, it got lighter.
Mm-hmm.
And that's where the prominence was, right?
It looked like it to me, yeah.
Okay.
I think your eyes are correct. Yeah. On that.
Yeah. So how did we treat this person? Obviously, voice rest right away for hemorrhage. She had some voice therapy for her speaking voice, much more than her singing voice. But there were some things with her singing voice that our therapist, who was Andrew, this is an Andrew and Dr. Gilberto case, which we are performing in their honor. She had a bit of singing voice therapy with Andrew to really work on the breath coordination and the passaggio in areas where she was having trouble, to decrease that amount of breath holding and strain that was happening. And then she was doing really well, and then she sneezed. And I wasn't supposed to show you that other film yet, because we were going to surprise you with it. But that's what happened. That comes from a sneeze.
That's after the sneeze?
Yes. So she had had a little hemorrhage, or not necessarily little, she had had a hemorrhage, had come in, had worked with Andrew, was okay. Then she comes back with a problem, and we see this. So in the first time that we saw her, Dr. Gilberto felt like, yeah, we see some ectatic vessels, some prominent blood vessels, but let's see if we can control this and not have another bleed. It's going to be okay. Not have another bleed without going in to treat the ectatic vessels with a laser. Well, apparently, her technique looked great. Her vocal fold doesn't look so great after a sneeze. So then they went in and they did the laser treatment. And then we've got the post, and this is post laser treatment. And you know, time, there was some time.
Yeah.
We're going to say in, sniff back and forth. In.
Everything's moving well, vibrating well.
Please pass the piece of potato.
Please pass the piece of potato.
On the first 2 lines of happy birthday. Can you feel that clear again? Then hold out that last note on. See if it gets straight tone.
We stop that right there. So this is another great point that Dr. Bott makes a lot, which is you can see that those are not perfect vocal folds, right? But she is working, she's getting paid to work, she's not vocally fatigued, she sounds pretty darn good. She still has some hourglass glottic closure, especially at her high notes. She's got a bit of prominence in the mid-chord, but we're not treating the picture, we're treating the patient. So it's okay that they're not perfect. In fact, we expect to see some not perfect things on people who are using their vocal cords in this athletic manner. Davida?
So, okay, so she was doing fine and then she sneezed.
Yeah.
Then, like, something was different with her voice, or did she
Yeah.
actually, like, see blood?
Her voice changed immediately.
Okay.
Sudden voice change.
So that blood never gets out. That's
It
something
resorbs from where it is.
Right.
Does it ever get out?
Okay.
No.
I was just curious
So
about how.
it's in this layer, the vibrating layer, just underneath the lining.
Okay.
Yeah.
So she just knew that that something had changed with her voice.
Yeah.
So okay.
Yeah. Thank you.
Mhm.
Okay, any questions on that case? Okay, so second case, 41-year-old female worship leader, hoarse, vocal fatigue, loss of range, hard getting onsets in the range where she's having difficulty with pitch control. She comes in and we see this. So this appearance is super common.
And as long as you can.
I'm interrupting myself. This is inhalation phonation here. And actually we have the pictures of inhalation phonation. Good. So this is when I told her to, and you see how her little bumpers come out? It's good. Mud flaps. I call them mud flaps. So she's got something that we see a lot of with singers, which is bilateral vocal fold polyps that are translucent. Some people call them pseudocysts. In our clinic, we call them polyps. They're soft, they're translucent, but they really get in the way of closure, and they can make the vocal folds heavy, and it can really affect. So we put her on voice rest and steroids, and after that, we see this. Her chords are still not perfect, obviously, but that is also inhalation phonation. I wanted apples to apples, and you can see how much better she looks. Unfortunately, the secret truth is that first film I showed you was when she came back like over a year later, and she really was not terribly compliant with therapy. She just couldn't quite, she has a lot of stuff going on, kids, blah, blah, blah.
Mhm.
So it kind of, the therapy is a really, really important part. It can't just be voice rest and steroids. We have to, you can't put on the old shoe that gave you the blister. You need a new one. Okay, what's next? You.
All right. So case 3 and 4 have more of a procedural surgical point to them. So this one's really an interesting case. This is a 55-year-old vocalist who presented with change in his voice, loss of really his lower register, but just altogether his voice was fundamentally different after an extended period of intubation. So he had been intubated for several weeks. And then obviously he was better medically, doing well, came to our clinic. His voice just never recovered. And it was a huge strain because he just couldn't speak or sing as well as he had been doing before. So this is the exam.
Little lamb, Mary had a little lamb, its fleece was white as snow.
Good, now sing something hard. There you go. And now try. Now try. Try. Good, and now try relaxing your tongue consciously. And don't worry so much about creating that resonance. Meow, 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 meow. Okay.
Just breathe. Sorry.
So at this moment, I'm thinking, oh my God, he's got so much tension. Look at this.
Yeah, couldn't even see his vocal cords until now.
Can you clear your throat and then swallow? Good.
Okay, so maybe I'll pause there for a moment. What do you all hear or see I know I'm putting everyone on the spot, but yeah.
Well, I mean, it was like, okay, where is vocal cords? Is it, you know, because always there's like these things hanging down,
Yeah.
and then finally you can see them. But is that part of? Is there a problem there
So
with
the
that
where
extra?
the vocal folds part, that's muscle tension.
Okay, I see.
And it's
Okay.
compensatory.
That there's so much
Right.
happening that you can't even
Yeah.
see past that to the
Yeah.
to the actual
And
cords.
so I'm trying to do exercises with him to get some of that tension gone so we can see better. When we finally do see,
Anybody see anything interesting? It's subtle.
I
It's,
see red.
yeah.
Is there's like a tear or something?
Mm-hmm.
Do I see that? Am I seeing something at the bottom?
Yeah, I think that's
Or
both.
the front?
We were both thinking that. Like, there's something not right.
yeah,
That's strange.
yeah.
I don't
I
know.
those was maybe mucus that was
It was like,
holding
is
the
there like
cords together.
nodules or is it torn? Is there torn under that? What happens?
Yeah. Here, I'll play it. I'll play it again.
Okay.
It's an interesting. And then one other question I have is, this is a male. You know, booming voice. What do you think about his voice?
A little bit of Kermit.
Yeah.
Kermit. Little Kermit the Frog. A little bit.
Kermit
Yeah, yeah,
Mhm.
super erotic, yeah.
And you know, fundamental frequency. You know, let me just go from the middle portion.
Do it when he's not singing. Go back to when he's not singing.
Yeah, it's right under this.
Just breathe.
Interesting.
Sorry. Just breathe, try not to swallow.
Very lumpy looking.
Oh yeah, it's like,
Yeah, it's like a.
it looks like it's
I would think that's
like
mucus.
a web or something in there. Is that what that is?
Nice. It's actually,
No chance.
I don't know, we have an anesthesiologist. Have you ever, this is a post-intubation web. Yeah.
Oh,
Yeah,
wow.
Post intubation web.
Yeah, it's just trauma from the endotracheal tube. And this is not even a web, it's actually a mucosal bridge. So the vocal folds,
This is pretty remarkable.
yeah, anterior to this look quite okay. But you guys did really well because, sorry. But this was referred to by a general otolaryngologist, and I totally get it. When you look with your plain light, it actually grossly looks like both vocal folds are doing what they need to do. And no, it's no fault to this person who referred, it's just that the stroboscopy allows us to see a little bit better tool. So this is a unique case in which we went straight to the operating room. We didn't do any kind of therapy. And the pitch, obviously I didn't really notice it, but he says booming voice, loud bass tones, that's his thing. You know, I think of vocal folds a little bit simplistically at times like guitar strings. If you're only vibrating a portion of the string, the pitch is higher because it's a shorter, shorter vibrating surface.
Perfect. Wonderful. On one breath, as fast as you can, count from 1 to 10.
1 to 2, 5, 6, 7, 8, 9, 10.
Good. And can you hum Happy Birthday for me? Good. Very good.
So we cut that little web or mucosal bridge, and you know, obviously we're ruling out other things, but yeah, a substantial improvement in the voice. Any questions about that case? Yeah.
It's like,
I'm sorry.
go for it.
Okay, so it was caused not by his singing, because obviously this is not his regular singing voice. If he's a big booming
Right.
bass, baritone, and he sounds like Kermit, that the tension in there, but it was caused by the injury of the long-term intubation, which scares the crap out of me.
Yeah, and
But, you know,
everybody has different motivations when you're really sick. They want any breathing tube, and sometimes, I think for his particular case, they wanted a large endotracheal tube because they could do bronchoscopy, so clear out the lungs.
Okay, it was something that was in his, it was.
Exactly, and so there's motivation. They're thinking about, let's get you through
Sure,
this
yes.
hospital stay.
They're thinking
Right.
about saving his life as
Right,
opposed
exactly.
to his.
Right.
Okay.
And it looks like a lot of that compensatory stuff went away after surgery,
Right.
Because he was trying so hard to get sound with a
Right.
physiological problem.
Yeah.
Okay.
And I probably would have I would love to have seen how he did with the difficult stuff afterwards. And this, I think you said, was only
Yeah,
like
this is a week out, so
post-surgery.
he's still, you can tell he's still a little timid with doing things, but he'll be seeing us in a couple months in clinic, so we'll see.
So can you show in this picture, what do you take out when
Yeah.
you do surgery?
So this little web here. Yeah. So hard to find the right moment, but the web that connects, or the mucosal bridge that connects, we do this transorally with a really fine laser, and we excise that mucosal bridge and not try to violate any deeper structures on the vocal folds.
Also, you just kind of.
So you're only affecting the bridge and not the actual.
Yeah, I mean,
Can you point it out on the picture, in this picture?
this might be the best picture. Again, when I pause it, it doesn't look as good, but let me see.
This is kind of red.
Yeah, you can see this.
There.
Well, I know.
That should be open way
Yeah,
down.
it should open.
Oh,
Yeah,
there you go.
that was
There
great.
you go.
Yeah.
Okay.
You can see a little.
It looks like an X. Yeah.
Dude. Yeah.
You can see a little daylight here. You can see a lot of air here, but there's here. And as a general rule, you don't want to cut more of the vocal fold than you have to. So we take as minimal as possible. We can always come back. You can always take more out if you need to later. I think he's doing so well that he probably won't need any more surgery, but less is more when it comes. Yeah.
I'm sorry, less is more.
Yeah.
I'm curious about, okay, maybe this is a stupid question, but so you did it with a laser, right? But how do you, this is what I've never understood about lasers. I mean, lasers, like people get into trouble for like blinding pilots in commercial airplanes from Earth to, and I'm just curious, and maybe this is, not the point, but how do you cut that with a laser without it hitting the, further down in the vocal cord?
Yeah, no, that's the hard part. And you have to get certified with laser, privileges. There's a lot of safety. We protect the eyes.
Is there something that you put behind it so that when it hits, it hits
We do put a pledget behind, you're right, so it absorbs. And just so you know, all lasers have different properties. The laser that this is using is called a CO2, carbon dioxide laser, and that preferentially gets absorbed by water. So water tends to be in all our tissues, but if you put, a dry pledget or something behind it, it won't burn as easily. We keep the oxygen really low because we don't want to create an airway fire. So there's a lot of, sorry, I feel like I'm.
No, this is helpful. It's
I'm
cool to
getting
know.
But yeah, these are, we do a pre-surgical timeout. So that's our surgical timeout. How do we have everything we need? But then we also do a laser safety timeout. So even before we put any fire.
How a particular individual's tissue.
We have a checklist. We go through each checklist, has the anesthesiologist put in a laser safe endotracheal tube, because that's another thing we don't want, obviously to burn, because there's a tube here as well. So there's a lot of
in the operation.
Right. Exactly.
One really cool part about this, getting onto a slightly less disturbing topic than being having an airway fire. If you guys noticed at the beginning, it looked like we were just seeing vocal cords.
It just looked like a wall of flesh.
And so, because of the fact that we are really in there, we're doing the unloading, et cetera, we were able to see, oh no, there's more under there that we're not even seeing. So if somebody comes to us from a standard ENT who's done a plain light exam without a speech pathologist present, we would be more able to see something like that.
Yeah, this is a rare case. Again, surgery is often not the starting point. And then, our last case, this is a 27-year-old male who had microsurgery, phonomicrosurgery of a vocal fold polyp. I think it was done in Colorado, not here. And he presented to us with some loss of range and really throat pain, right? Throat pain is
Yeah.
the main complaint.
Throat pain and a huge gap in his top range.
Right. And so this is what well, I skipped over a little bit. So he did quite a bit of voice therapy and had done voice therapy in Denver, and then connected with our group and worked with Julie, and then also connected with a physical therapist who specializes in chronic pain. He got a lot of benefit from this, especially at the throat pain level.
Yeah.
You agree?
Absolutely, yeah.
But he was still having some loss of upper range and some, we'll show you the exam here.
Are you guys seeing where the little scar is?
Toward the top?
It's
I'm sorry. This is really hard. I mean, our eyes are drawn to this, but this is after years and years of looking at this. So I don't know. Does anyone have any?
Was it like slightly toward the top of the cords?
Which vocal fold did you see it on?
Oh, I mean, I was looking like, okay, it looks like they're approximating, but then there's like more. Oh, look at that. Okay, yeah. So that's right there, like above the two hourglass. No.
Sorry.
No, I was seeing it in the. I wasn't looking at anything on the side. But
Oh no, yeah.
But right between those, the colon, as in writing, not the colon.
Oh, you're thinking it's
Where it's
right
coming
here.
together. Yeah.
Yeah.
No.
It's so subtle. It's so subtle. But the fact that he had a prior surgery in the past is the clue. And again, most.
That's where it seems to be coming together closer at that
Yeah,
point.
that isn't it.
Okay, sorry. All right.
It's hard to freeze it because it's such a video dependent type of thing. Anybody else have any? I can tell you all, but it's not a quiz. But
Maybe, but no, I'm not sure.
2 for 2?
Point it out and then go back.
What was that?
Just point it out and then go back.
Yeah, okay. So what it is something called a sulcus. And basically, after the polyp is removed, the epithelium, which is the outer layer of the vocal fold, gets tethered to the muscle underneath that supplies bulk to the vocal folds. Normally, there's a vibrating layer. And so I'll play it again, but it's subtle. It's right throughout here. And we'll play
Like a little divot.
Like a divot. There you go.
Oh, gotcha,
Yeah, divot's
okay.
a great word.
Okay, yeah.
Do you see that?
Oh, yeah.
On the, kind of on the inside.
Yeah.
Yeah.
It's
So is that why the right fold is so much narrower than the left?
Not so much. It could be the angle that we're looking
It's
with
like a
the,
line. It's like a
yeah,
line.
exactly.
Yeah.
that's right. That's right.
It's like a flag unfurls a little bit. It like it goes like this,
And
then
when you
see-
get something like that, it's like a breakwater for the wave.
Wow.
So the mucosal wave stops propagating.
And so this is a more obvious
Oh,
one.
that's good, yeah.
So
There you can see it.
Julie,
Okay,
when
yeah.
she's doing the exam, can actually slow the wave down with a lighting phenomenon, so it's getting even slower. Then you can see it more clearly.
Oh, wow.
See, it's not vibrating as well on this side.
Mm-hmm.
Yeah,
Because of that
it's- the other one
sulcus.
is the other cord is very straight, and the other one is
Yeah.
it's deceiving though.
Yeah, right
Yeah,
there.
really,
That's
yeah,
a good
yeah.
still.
With the dark line.
Mm-hmm.
So
Interesting.
while he was doing a lot better, throat pain was under better control, by and large, he was moving in the right direction. We felt like there was value in doing something about this. So we went to the operating room, and less is more, but all we did was very precisely inject steroids just underneath this lining here. The idea is it breaks up some of that scar that's tethering the lining. And for singers especially, we will do the first injection in the operating room, assuming it's safe. just because we really want to make sure that we get it as precise of an injection as possible, not do it while the patient's awake in the office. It's always an option. And so this is after one injection. You can see that it's still there, but it's not as prominent, but you can still see it. It's not gone.
It looks like it's not quite as stiff. It looks a little more flexible.
Yeah.
And honestly, as much as we care about how it looks, assuming nothing looks bad, it's really, the proof is in how he feels. And if he feels like he's able to do more, and now we're doing more injections, now we're kind of spacing it out every 6 weeks, aim for 2 or 3 injections, and the second and the third one, we'll do it in the office. But we know at least with the first one, we got a really good injection.
You got good results.
Good result, yeah, exactly.
Yeah.
Yeah, it's
Some
question
questions.
time, yeah.
Okay, so, let's see how I want to, so this guy, I forget what his whole history was at the beginning that you showed, before you showed the pictures. Was he studying with somebody?
Yes,
He was
Dr.
working
Reagan.
with somebody? What caused this? So was it just bad singing or too much singing?
He was
oversinging?
not studying with Dr. Reagan before he came to us. I feel like he was in a program in
Like School of Rock or
Colorado.
something, or?
No, I'm not sure. But he had a polyp that was surgerized, and so
This is
my
scar
question
tissue
to
from.
myself is that what happened?
Definitely, yeah,
Right.
I would say.
So he wasn't doing anything wrong, he was just trying to work through whatever he was left with from the
He
operation.
might have done something, quote, wrong to get that polyp in the first place. It's possible. But I think that this kind of a sulcus is more likely
Yeah.
post-surgical result. And we work very, very closely together on any surgical case that involves the tissue. Well, all of them really, but and so we're doing voice therapy to continue to mobilize the tissue to make sure people aren't over talking or straining. We give them a new shoe, and we also work to vibrate the tissue early and often.
It's hard to know whether the surgery, maybe a little more aggressive. It's just hard to know. And sometimes despite best efforts, things like this can happen, but it's just a good example of, even from the first visit, we saw this, but we didn't immediately jump into putting steroids in there. We tried everything else, and then at the point at which he still feels like he wants something more, then we offer it. So.
What's ongoing treatment for this? Is it resolvable? I've heard that sulcuses are really hard to
Sulcus
treat.
and scar, we were just talking about this.
Yeah.
It's one of the treatments. You'll find 50 treatments in the literature for scar. No one treatment has just been the answer. Steroids tend to have a really good risk-benefit profile, very low risk, and can help. So I feel like a lot of times people will talk about excising scar using laser. Personally, one exciting treatment that I'm hoping that we can do in the coming years is the platelet-rich plasma injections, PRP. And so when I was at USC, we started doing this study, and I think there is some evidence, especially in other parts of the body, that maybe PRP could be a more durable, better answer than steroids.
That's something that's done in like joints too? and-
Exactly, yeah.
Okay, I know
So
for
you get
horses, they do that.
Right, you get a little bit of your blood, spin it down, and you get this pellet, and exactly, yeah. So, yeah, there's a lot of technical advancements, I think, that are possible with this, so. All right, awesome.
That's all us.
Awesome.
I think we were going to have a chatty, breaky time.
That's right. That's
Yeah.
right. Unless there's any more.
Have a question?
Yeah,
Question.
absolutely.
Yeah, we can,
Or we're just.
And you guys, we can do questions while you snack, or how do you want to do it? Because we're at 3:15, and I don't want to run into your meeting.
I would say if there's any questions that you think would benefit the group, let's have a quick question here. Holly's got a question.
I have a student who desperately needs a baseline exam. She's been chronically hoarse for a while. she's super squeamish, and her mom thinks that there's some risks involved in this. And I just wonder if you have some advice for some spiel we
Her
can
mom
give
thinks
them
that there's a
to-
risk involved in having an exam.
Yeah,
How old is this person?
college student.
How old is this person's mom?
I don't know.
Yeah, it's really, you know,
There could be a little bit of religious
see.
resistance to medical treatment
I
going
see.
on there. I'm not sure.
Are they Christian Scientists or something?
I don't know, but I know they're very religious.
well, you know, we'll take very good care of them, and if there's anything that happens that they don't like, we'll stop. Right?
Would
Yes.
this be an appropriate person to say maybe you'll go through the mouth before you go through the nose to see how they do?
If that would make that much of a difference to that person, yes. The
Okay.
problem for me, and I've converted Dr. Bott, I think, of going through the mouth first is that we're not gonna see the muscular patterns. So I'm not gonna know, I mean, I'll know anyway, because I can hear it, but it's really lovely to have a picture, and then we can even do biofeedback during the exam. But if the best we can do is a rigid, that's also amazing pictures, as you saw. The pictures in the rigid are super clear, and they can tell us if there's any tissue damage, and we can see the movement. So, anything to add to that, Dr. Bob?
Let's see if there's
That's
any.
perfect.
Do you have,
See
like
if
that
there's
video
any-
we watched, do you have anything online like that? I know other people do, maybe watch
We're
it with them so they
actually-
can like watch someone go
Yeah.
through an
Yeah.
exam.
Yeah.
We're
I've-
actually going to put that video of Abby getting scoped on our website.
Good.
We just finished it last week, was it?
Yeah, probably.
Yeah, so we're gonna put that up. I don't think, we could do an intro.
Good
We
idea.
could do a rigid.
I just find sometimes people who are resistant, they're just afraid of it.
Yeah.
And you
Yeah.
just
They
sit
get
and watch
desensitized.
one with them and
Yeah.
explain what's happening.
Yeah.
Maybe.
We could absolutely
idea.
do that, and I love that you asked for it, because we're just about to do at least the nasoendoscopic.
I just will go on YouTube and find them.
Yeah.
But it would be great if it was actually at the same place.
Yeah. There, I think, USC has one up, don't they?
Yeah.
Yeah, USC has
There's a
one
few
up,
up there,
yeah.
I know this is like a kind of like a broad question, but just, and we've talked about different cases and stuff like that. I just wanna know, I just wanna be like really aware of what to look for in a student. Like, is this normal? Is this not normal? Like I said, it's kind of like a really, probably there's a lot of answers to this, but, do you have any like specific things that I should be, was there?
Yeah, so the
You talked about that a
beginning,
little bit. but-
yeah, I did, and
Yeah.
we're just gonna bring that slide up, because it is exactly the most important thing for you guys to be thinking about. When do I say, oh, you've got a cold, wait, and when do I say, get thee, right? So,
Yeah, sorry for
these are,
repeating
no,
yourself.
not at all.
No, it's
This is the
helpful.
biggest piece of why we're here.
Yeah.
So baseline evaluation, as you were talking about, what's going on in there? Voice change that doesn't resolve within 2 weeks. Like, even if somebody's been sick and their voice isn't getting better, that's a good reason to come in. For you guys, you're probably gonna hear more of the issues with, maybe there's a delayed onset, maybe people are complaining of pain, maybe they're having a lot of strain, maybe in spite of the technique that you're using, they have a, passaggio is a little tricky, but, you know, if you feel like, wow, we're working on this, it's working, it's not working all the way, is there a physiologic reason that could be happening or not happening? That would be number three, the persistent roadblocks. Yeah, did that answer your question?
Yeah, yeah.
Anything
it's a-
else that you're wondering about? Like, if I hear blah blah, should I be sending them?
Well, in addition to if I'm hearing something, is age a factor? Because I have an 11-year-old, and I just I know that there's voice changing that happens.
The male, female?
Female. So so I'm specifically kind of thinking of her in this sense because it's a really raspy voice that I just don't know where it's coming from or what could be.
Yeah,
Just
so-
started with her, so.
You know, I think we can see that age in our clinic. I think the operating room, that may be tricky. I think we can get maybe 13, 14, I think you can get into it, but we can see 11-year-old. Seattle Children's is starting to create more of a voice center too. I think
Wow.
it's still work in progress, and there are some new people who are also coming. But you know, I think there could be some resources there in their ear, nose, and throat department too.
Okay, all right, thank you.
But we have seen 11-year-olds in our clinic.
Okay.
So I just have a real quick, and I can talk to you about this. Have either of you, especially Julie, have you ever heard of a thing called Skinner releasing?
In a super peripheral kind of, I couldn't even tell you what that's about way. So no, let's just say no.
Okay, I want to talk to you about it.
Okay.
Anyway, okay.
Other questions? Is there anything else that we can do for you as a clinic? For you as a singing voice professional teacher, and you guys are obviously, since you're here, kind of in the upper echelons of what you do. What else can we do to give access to your patients, etc.?
If we are sending young students, is it good for us to send you an email? Is it okay for us to give you information? I don't know
Absolutely.
what the privacy laws
Yeah.
and all that.
So privacy-wise, you're not bound by HIPAA. I am.
Okay.
So privacy-wise, you can send me whatever the patient says is fine. And then when I see the patient, I can have them sign a release of information, or their parents sign a release of information, and then I'll be able to talk to them. Yeah? Or Dr. Bach? Yeah? But yeah, feel free. My email's on my card, and then Perform Voice Clinic, I get that one too. Anything else that we can do to help? Okay, let's eat cake.
Yay! Yay! Round of applause.
Wonderful.
Thank you.
Yes, no, thank you guys. We really appreciate these two being here on a Sunday. So when you say, what else can we do? I'm like, you're already taking time on your day off to spread the gospel and make this resource available. Yes. And I just wanted to say thank you for that, and for also the collaboration to really help people. I mean, for our people at home and our people here, I wanted to say, I know this can be a sensitive topic when we're providing a medical referral. And I think I'm going to speak from my own personal experience. I experienced a vocal injury, and had I gone down the rabbit hole of just going to a general ENT who didn't know what to look for, we're talking about adding months and months onto someone's injury journey when they can get coordinated with a team of specialists who can get them care, especially for someone who is having an acute injury. So I wish I had had that in my vocal injury process. And so when you saw me making the face about like the hemorrhage, I was like, yeah, that's what my vocal folds looked like in 2016 before I got help from a voice care team. So thank you, and we're excited to provide this resource at home. Let's eat cake. Yay! Thanks. We're gonna pause for just a second, and then we'll come back with our member meeting. Un momento.
responsible voice users.
Am I gonna be on screen?
Hi there, everybody. So sorry. I said 3:30 and it's 3:38, but we got to talking with everybody. So thank you for being back for our fall member meeting. And we're going to do another quick sound check here. Hopefully you can hear us pretty well from there and from the room. Yay, good vocal hygiene. So I'm going to officially call us to welcome for our 2023 Puget Sound chapter of NATS fall member meeting. Yay! Awesome. I wish you guys could see this. We have like the most amazing view of Husky Stadium and the water out the window. So thank you for joining us online and for tuning in to our amazing presentation from the University of Washington Medical Center's Performing Device Clinic. We want to kick it off with some officer reports just to get the 411 on where we were at. So I want to introduce a new board member, Amy Van Mecklin. Let's have a round of applause, everyone. Let's welcome Amy to talk about a secretary report.
Okay, so you'll tell me, hopefully this is right, that you guys had a meeting last June in 2022. So, okay, no one's objecting to that.
2023.
June was still 2023.
Oh, you had one in June of this year?
Yeah.
Oh, okay. See, that's why I should have asked more questions.
Oh,
Don't worry.
I misunderstood you.
That's okay. I thought that was weird. Hold on, I'm pulling up the drive with.
For our member meeting, actually, I
she's
think
right.
fall of 2022. I think it was September of
Okay,
2022.
member meeting was
Whatever.
June 18, 2022 or 2023.
Shoot.
Sorry guys. I should have been more prepared.
Well, you weren't with us then.
That's okay. I'm trying to remember, did we have a member meeting in June? I don't think we did. I think it was just the fall of 20.
Of last year.
Yeah.
Okay,
Mhm.
great. That's what I found. So.
Yep.
Okay, great. We're on this journey together. Okay. Okay, so last year, you guys, Megan took over as the president. And then we had a new board member at large, Jose Luis. And Holly took over for VP of membership. And Davida took over for senior scholarship committee. Great. And then the treasurer, Brandon, started as well, I think, or was added. Okay, great. There was a question about building a new website. I don't know if that has happened, but
Yes.
okay, great. Look at us. And then we talked about fundraising, ideas for diversity and inclusion, how to review applications and things like that. And then the senior scholarship, there was a tie for first place. Elizabeth H. and Darla's student, and Isabel, I don't know. And then there was a second place, one of Jose's students. And then there was some questions about how to feedback on that process, like if they should add some components like an essay or things like that.
They did.
Okay, great, excellent. And then, yeah, and then there was just a discussion about when to meet next, which is happening right now. So yeah, that was pretty much it.
Wonderful.
Yeah, do you want me to talk about anything else? Or
I think that's pretty much it.
Okay.
Usually, procedurally, what we do is call it to a vote and say,
okay, yes.
do we have any nominations to approve the minutes from our last meeting? I see raised hands from Katie and Davida. And do we have a second? I'm going to just say Christy's a second.
Great.
Another hand went right up. And all in favor, raise your hands. Woo, we're approving minutes from last time. Thank you, and thank you for Amy for stepping in. And thank you, I know DJ was gonna log in online, so thank you to our former secretary, DJ, who typed up the meeting minutes from the last time. Yes, I think we're gonna put a pin in the treasurer report just for a second. Was on the line with Brandon, seeing if he might log into the Zoom to provide that. If not, then I will go ahead and give a little update on the treasurer report. So I think that means next up, if we could bring up
Holly Boaz with our VP of Membership Report. Hooray! Here's Holly.
Thanks, Megan. So just a quick overview of our membership. We have 89 members currently active in the Puget Sound chapter, which is a good, healthy number for a chapter. But wouldn't it be nice if we could get over 100?
Yeah.
That would be super cool. So let's see if we can do that. Please let me know if you guys know anybody who might be a good candidate for our chapter or who is already a member of NATS but hasn't joined a local chapter yet. We'd like to get those folks involved. Or if there's somebody who's recently joined that I might not be aware of, I love to reach out to new members. In fact, I met a great new member this morning who just moved here from DC. Some of you probably know who she is. Her name's Kate Fraser Neely, and she's one of the co-authors with Nancy Boss of the Singing Through Change about women in midlife and beyond. So hopefully she's going to start getting involved with the group, but I love reaching out to those new members and making them feel welcome, so let me know. We also only have 4 student members right now, and I'd love to have more student members. So especially those of us who are at academic institutions, let's encourage those students to get involved and enrich their education as well. And finally, this is a new thing for our chapter. All of our emeritus members, we don't have that many, we have a few, but we probably will have more in future. Emeritus members now get to join for free. They already get to join the national organization for free, and now they will not have to pay chapter dues to be part of the Puget Sound chapter. Because we value our emeritus members. Yeah, I knew you were going to ask that question, so I went and I looked it up. You qualify as an emeritus member if you have been a vital part of the NATS community for 20 years or more, and you are 68 years or older. So, I think that's all I have to say. Any questions? Yeah, Keith.
From my previous experience, emeritus members can still judge.
Oh, yeah.
So I just want to encourage that.
We love our
keep
emeritus
happening.
members.
So,
Yeah.
Just wanted to say that.
Absolutely.
We appreciate that.
Does it have to be 20 years consecutive?
That's a good question. I can find out. Anything else? All right. Cool. Thanks, y'all.
Yeah. Thank you, Holly. And I think this is okay to announce too, talking with Nicole, our Northwest Regional coordinator for the conference coming up, she was also talking about providing free access to the conference, the regional conference at Seattle Opera, November 10th through the 12th, to our emeritus members. So emeritus members, come on up for free. Yay! Great. Before we bring up our kind of star of the show for VP of Student Auditions, Chrissy Rotarius, I think let's go ahead and talk about treasurer stuff real quick. So I heard back from Brandon, and the bottom line I want to share, I think I can probably provide access to the whole chapter in an email summarizing our meeting today, the actual balance sheets. We're doing well. We have $14,113.08 in our total asset column as of June this summer of 2023. And that is a net loss of about $2,000 from the prior year of June 2022. And so that loss represents all of the wonderful educational events that we've done, and also the awarding of our senior scholarships over the past year. We had awards for musical theater, and we also had awards for classical. And so we're just putting out money there for our educational events. But that is the balance, and I'll go ahead and send out those more detailed balance sheets via email if you want to have a chance to look at the health of our chapter dues, which are healthy, and we still have money in the bank. Any questions about that? Let's go ahead and bring up Christy to talk about student auditions, because things are going to be changing a little bit. Yes.
Hello, everyone. I'm Christy Rotarius. Okay, auditions. We have some changes, and I wish I had more information for you.
Hooray!
But here are the important things to know. We are doing virtual auditions again this year, but starting next year, we will be in person, and then we're going to switch back and forth between virtual and in person. We had a lengthy conversation about that. The reason for that is to maximize participation. We usually have a lot more people participate when we are online, but we know a lot of us are missing the in-person auditions. So next year we'll be in person, but this year we're virtual again. So that's exciting. Tentative dates. Registration will be from November 15th to December 28th. And judging will take place December 29th through January 12th. And the winners will be announced on January 13th. I say they're tentative because here's the thing. NATS, National NATS, is we have new software. So we used Auditionware to enter all our students, register everyone for the competition. We are no longer using that one, and they are going to train us on how to use the new one, but they have not told us when they're going to do that yet. They have told us we may need to shorten the length of our registration. So the date may shift, but it will shift to later, not earlier. So it will be within November 15th to 28th that you can register. It just might be a shorter window. I will let you know as soon as I know. And then, so there will be new software. So the way we've entered our students, I don't know how much it's going to change. I wish I could tell you. They're going to train me, and then I'm going to tell you how to do it once I know. So for now, if you're looking for information about categories and requirements, you can find that tonight. Katie is going to update the website for us with the handbook for this year, except the handbook still has the old information from the old software, so that will be changing. But the category information has been updated, so you can see the time limit and what songs your students need and all the categories. You can find that on the psnats.org website. I think that's it for me.
Otherwise, YouTube is going to be the thing in years past, as in years past. We're going to upload videos to YouTube most likely.
Yes, that should be the same, uploading to YouTube, as far as I know. It's just like putting everything into the system on that part might change, and I'll let you know that. Do I see a question?
Oh,
yes.
I know you won't know all of that detail, but do you have a date in mind, or are you going to do like a similar thing where we have a let's meet and go over stuff before people start entering stuff?
Yes, we are going to have a meeting that we will call mandatory, but of course we'll record it if you can't be there. That will explain everything in detail. I had planned to have the date to tell everyone today, but I don't know when I'm going to know. So I'm going to hold off, and we'll pick a date once I know when I will have the information to pass on to you. But look out for that. It'll probably, hopefully, be early November. That's what I hope. Anybody else have a question? Yay. Okay. Who's next?
Yay.
Thanks.
Thank you. I know that's so frustrating to be like, we're going to have information later. So it's a put a pin in that. As for right now, please proceed as you have in years past, informed by the category information that's going to be on psnats.org for the correct time limits and categories for our student auditions this year, which, quick plug, we had 3 national winners from our chapter last year, y'all. Yes, with from Holly Boaz Studio and Shanhan. Yeah, so woohoo! That's pretty cool. That's pretty amazing to get that far. So big round of applause for that. Also wanted to provide the group a quick update on our fellowship program. We did award 2 fellowships last year. And we have students getting this update from Jordan Palmer, who wishes she could be here today, but we thank Jordan Palmer for leading this committee. She said they have 2 students. Nathan Gibson is an incoming senior, or a senior this year at Jackson High School, and he's been working with a new NATS member, Aaron Norman. And Helena Abie is an incoming senior at Meadowdale High School, and is working with Jordan Palmer. And so both of those students are receiving financial support from the fellowships program, which receive fundraising through Dr. Kari Reagan's studio. So we are so happy to have both of them. And the plan is to continue with the studies for those 2 students and continue fundraising to perhaps add more students and more teachers onto the program. So we're so happy to have that option for our students and to really speak to the mission of providing access to quality vocal education. And that's not always accessible, especially this day and age. So yes, thank you. Then moving on, we want to talk about our upcoming events. Yes, so hot off the presses after today, which if you're on Zoom, I know you appreciate being in your pajamas, but you missed out on some rockin' bakery treats today. That could have gone well with said pajamas. You could have come, we wouldn't have judged. We're gonna have a master class with a Puget Sound NATS member, Candace Donahue Pullum. It'll be Sunday, October 7th. It's coming up 2 p.m. and it's gonna be entitled Climb Every Mountain, working on different musical theater styles with a master teacher here within our own chapter, and it'll be taking place at the Raisbeck Performance Hall at Cornish College of the Arts. So more information to come on that. We've got an email out from Christy on submitting your students if you'd like to have them participate. And your email, if we could say it out loud, Christy?
Yeah, it's Christy@rotariousvoice.com.
Christy@rotariousvoice.com. We'll put that in the email.
It's on the website too.
On the website too. You have no excuses. We want to have singers for that. For those of you who responded to our ballot the past spring, nominating our new officers, the feedback we asked for around surrounding events was pretty clear. Master classes were everyone's jam. So we'll be planning 3 of them this year, the first one being our musical theater one coming up in October. Then, if you haven't done so already, Northwest Regional Conference. You still have some time to register by early bird registration until October 1st. So there's gonna be some fabulous things. You really, I don't know about you, I always come away from those events feeling revitalized and energized. It can be easy, especially as an individual private teacher, to get a little, what's the right word I'm looking for? Kind of fatigued, you know? And so to really get an injection of some learning and some networking with our fellow teachers, it's so very important. We've got some fabulous presenters coming, including Nicole Hannick from University of Portland and Lori Hicks, yes. And Lynn Helding, oh my gosh, I can't believe I would forget Lynn Helding. In fact, I don't mean to put Holly on the spot. Did you want to say anything else about our Northwest Regional Conference, Holly?
I can say something about NATSA.
Yes, let's say something about NATSA.
You wanna? Okay. We have 13 participants.
There are 13 participants for NATSA this year. Whoa! We had how many last year? 5?
We had 3 2 years ago.
3 2 years ago.
So that's good.
That's amazing. 13 participants for NATSA, which will be November 10th.
November 10th, we'll start around 11 a.m. and the preliminaries will go till about 5.
Okay.
And then the finals event will be in the evening. Please, everybody, come to the finals.
Come to the finals event on November 10th. It's at Tagney Jones Seattle Opera.
7 p.m.
7 p.m. November 10th. That is something we shouldn't miss.
And that's the day before.
That's the day before the official start of the conference. The next day on Saturday, the 11th. Yes. Fabulous idea. And in a reverse come from away, we are hoping to host people of Canadian descent and maybe Alaskan descent, right? Or for people from up north who need a place to stay. Let me just say that. So we are having Alex O'Donoghue helping with that. If you want to get a hold of Alex, if you're interested in having somebody stay with you to help them offset the cost of housing, that would be great. Alex's email is voicesthatgetheard@gmail.com. And then TBD, our next masterclass we're looking at is February. Information to come for a jazz masterclass. And then Saturday, March 16th, after our winners announcement in January, we're going to have our Student Auditions Winners Concert again at Seattle Epiphany, which has been such an amazing highlight the past couple of years. And big thanks to Katie Stevenson and Brian Feeler for helping make that happen with Seattle Epiphany. So mark your calendars for Saturday, March 16th. We'll also look at having a spring member meeting, and we're going to look at moving up the Senior Scholarship Awards from June to April to coincide with our spring member meeting. So also TBD on that. And finally, we're in talks with Seattle Opera to do a classical masterclass with one of the artists from the Barber of Seville in partnership with Seattle Opera. So that is coming out of May. Phew, there's a lot of things coming up. So be sure to mark your calendars and come on out and join us to get the most out of your NATS membership. We have a question from Katie.
We'll put all of this on the website too.
We will put all of this on the website, so please look for more information there. Am I missing anything? Does anybody have any other questions, thoughts? Okay. Well, with that being said, thank you so much for joining us for our presentation and NATS member meeting. Hooray! We look forward to seeing you at our upcoming masterclass and for more information about our student auditions coming up. Oh, quick last question.
If they have any questions, if anybody has any questions.
Yeah, I don't know if we have any questions from October 7th is a Saturday from Laura. Yes, sorry, I think I said Sunday and it is a Saturday. I put Sunday on my sheet and that is wrong. It should be Saturday, October 7th. So thank you for checking with the room there. Wonderful. Awesome. Thank you everybody for joining us, and thank you for joining us online. We'll see you again at our next meeting.
Bye. Yay. Yay. Thanks everybody.